Good evening, everyone, and welcome to tonight's edition of Waxing Clinical. We're very excited to have joining us tonight Dr. Nico Fang. Dr. Nico Fang is a specialist orthopedic surgeon practicing out of Netcare Rosebank and Netcare Moore Park hospitals. He completed his undergrad at the University of Pretoria and went on to do his specialization at the University of Witwatersrand. Dr. Fang has done a number of fellowships, including a fellowship at the Hand Surgery Clinic in Chris Hani Baragwanath Hospital, as well as a fellowship in hand surgery and microsurgery at the Kleinhardt Hand Institute in Louisville in the United States. He also has multiple publications, including publications in the South African Orthopaedic Association Journal, and is also a member of the South African Society for Hand Surgery or Surgery of the Hand, as well as the American Society for Surgery of the Hand. We're very, very happy to be having Dr. Fang with us today, and he will be presenting on extensor tendon injury. So thank you so much, Dr. Fang. I am going to hand over to you. If there's any questions, please feel free to just note them down in the chat. We'll address them at the end of the presentation, and then otherwise we just request that you stay on mute and keep your video off for the duration of the presentation. Thank you so much. Dr. Fang, over to you.
Thank you so much, Dr. Kawana, for the generous introduction. I hope everyone can see my screen. Is it projecting properly?
Yes, we can see your screen.
Okay, just the obligatory check. Okay. So good evening, folks. This evening, I've obviously chosen a topic that I'm sure we've all come across at some point in our careers. Extensor tendon injuries definitely is a very common injury that we see in the realm of hand surgery. And obviously, we are all from different backgrounds. So the goal tonight is not to turn everyone into hand surgeons, but rather to touch on some important points regarding this topic. And to try and make it interesting and applicable for everyone. So without further delay, let's get cracking. I don't have any disclosures. So obviously over the past century, a lot of focus have been centered on flexor tendon injuries, which as a result has kind of led to the misconception that extensor tendon injuries are easier to treat. However, the mechanism of finger extension is way more complicated than that of finger flexion. And that's because extensor tendon injuries are on the more exposed dorsal aspect of the hand, and they're more prone to injuries. So this is the reason why extensor tendon injuries account for more than a quarter of orthopedic soft tissue injuries. And if you look at the epidemiology, most of these injuries occur in men in their 30s. And the thumb, followed by the index and middle finger, are usually the fingers that are commonly involved. So our objectives this evening is to give a brief overview on extensor tendon injuries, and we'll focus on the relevant anatomy of the extensor mechanism, the evaluation of the extensor tendon injury, and we'll also explore the different types of extensor tendon injuries and its management thereof. So looking at the anatomy, the extensor mechanism of the hand is pretty special in that its complexity increases from proximal to distal. So the four extensor tendons originate from the common muscle belly of the extensor digitorum communis, about 4 centimeters proximal to the wrist at its musculotendinous junction. And obviously on your index and small fingers, the extensor indicis proprius and extensor digiti minimi have individual muscle bellies which allow for independent extension of these fingers. So these proprius tendons are generally found on the ulnar side of the adjacent communis tendon, and hand surgeons love to utilize these tendons as grafts and donors, especially in our reconstruction cases. Now moving on to the wrist, the superficial extrinsic wrist extensors originate from the lateral epicondyle of the humerus and the posterior border of the ulna. And your stronger wrist extensors are on the radial side, namely the extensor carpi radialis longus and brevis. And then on your ulnar side, you have your extensor carpi ulnaris, which acts as a wrist extensor in supination and as an ulnar deviator in pronation. For the thumb, there are 3 deep extrinsic muscles that insert onto the thumb. One we're obviously more familiar with is the extensor pollicis longus, which inserts on the dorsal aspect of the distal phalanx, and its job is to extend the thumb at the interphalangeal joint. Now, the extensor pollicis brevis inserts on the proximal phalanx, and its job is to extend the proximal phalanx at the first metacarpophalangeal joint. Now, what is key when examining these lacerations, especially to the extensor pollicis longus tendon, is that you cannot simply test the EPL by just extending the thumb at the interphalangeal joint. And this is because the interphalangeal joint is also extended by the extensor pollicis brevis and the thenar intrinsic muscles. So to test the EPL independently, you have to ask the patient to place their head flat on the surface of a table and ask them to lift the thumb off the table. If they're unable to do so, then there is obviously likely disruption of that EPL tendon. And lastly, you've got your APL, or abductor pollicis longus tendon, and this usually inserts on the radial aspect of the base of the thumb metacarpal and abducts the thumb at the first carpal metacarpal joint. Now, at the level of the wrist, the tendon is obviously coursed through 6 individual synovial line fibroosseous sheaths. These form the 6 extensor compartments, which I'm sure some of you can recall has always been a favorite anatomy class question. So just to recap, the first compartment houses the abductor pollicis longus and extensor pollicis brevis tendons, which are the main culprits for your Duchenne tenosynovitis. Your main wrist extensors, your ECRB and ECRL, transverse to the second compartment. Your EPL is contained in the third compartment, which is ulnar to your prominent listus tubercle. And this is pretty much your lighthouse to approaching the wrist. And your extensor digitorum communis is housed in the fourth extensor compartment, together with the extensor indicis proprius to the index finger. Your extensor digiti minimi is housed in the fifth compartment. And lastly, your extensor carpi ulnaris, which is housed in the sixth compartment. The ECU also has its own subsheath that prevents subluxation during pronosupination. So another structure to note is the junctura tendinum. Yeah, these ones. And these are stout fibers that link the finger extensors together and prevent independent extension of the fingers. So what is the significance of this is that obviously if the extensor tendon in the finger is cut proximal to these structures and neighboring finger's extensor tendon is intact, then the injured finger may still be able to extend because the neighboring tendon can compensate for the damage. So you need to, when you're examining tendon injuries, especially in zone 6, which we'll come to a bit later, this is important to note. Now, focusing on the extensor mechanism more distally, obviously as the extensor tendon passes over the metacarpal phalangeal joint, they are tethered by sagittal bands on each side, which keep the extensor mechanism gliding centrally along the midline. And if the extensor tendons are not maintaining this midline, such as in your sagittal band rupture from trauma or from rheumatoid arthritis, then an extensor lag can result. Moving beyond your metacarpal phalangeal joints, the extensor tendon becomes way more complex. The EDC tendon trifurcates before reaching the PIP joint. And in this region, the remaining central slip crosses the PIP joint and attaches to the middle phalanx and is responsible for extension at the PIP joint. The remaining radial and ulnar portions of this EDC trifurcation join the lateral bands and interossi to form the conjoined lateral bands at the level of the middle phalanx. And they then proceed distally and cross the DIPJ to form the terminal tendon, which attaches the distal phalanx and is responsible for extending the distal phalanx. Other important structures to note as well in the extensor mechanism is your transverse retinacular ligament, which connects the lateral bands to the volar plate of the PIP joint and prevents them from subluxing dorsally during PIP extension. And then obviously your triangular ligament as well connects your conjoint tendon bands over the middle phalanx and prevents them from subluxing volarly during DIP flexion. So disruption of these important structures may lead to deformities at your swan neck and your boutonnieres. So looking at your biomechanics of the extensor mechanism, the extensor mechanism is pretty much unforgiving. So in an anatomical study done by Boyes et al., they noted that the amplitude of excursion of the finger is about 5 centimeters. However, the caveat to that is that most of this excursion occurs over the forearm, the wrist, and the dorsal hand, and not in the fingers. So what is the consequence of this? If you had to lengthen the extensor tendon by 1 millimeter over the dorsum of the hand, this would result in an extensor lag of about 7 degrees at the metacarpal phalangeal joint. However, if you had to do the same and lengthen the tendon by 1 millimeter over the proximal phalanx, it will result in an even larger extensor lag at approximately 12 degrees at the PIP joint. And if you do the same at the terminal tendon, it will result in a 25-degree lag at the DIPJ. So what this means essentially is that there's actually very little excursion of the extensor tendon distally over the fingers. And this is important because any small tendon gaps or over-tightening of tendon repairs can lead to dramatic extensor lags, or even worse, restriction of flexion of the fingers. So this is important to take note if you doing surgical repair of these tendons. Now, evaluation of extensor tendon injuries generally begins with a detailed history and must include the mechanism of injury, the position of the hand and fingers at the time of injury, the age of the patient, occupation, and handedness. Knowing whether a human bite was involved is also very important, as any contamination would need formal irrigation and debridement. And generally, for examination of these injuries, we start with inspection. Any open wound to the back of the hand should raise suspicion for extensor tendon injury. And neurovascular status should always be tested and documented before any local anesthetic is given. And this is especially true with your more proximal lacerations, where your posterior interosseous nerve or superficial radial nerve may be involved together with your extensor tendon injuries. Extension in each finger needs to be tested on a joint-by-joint basis and in isolation, looking at the active range of motion and movement against resistance. And one needs to obviously pay special attention to the zone of injury of the extensor tendon injury. So after initial assessment is performed, radiographs must be taken to assess if there are any associated fractures, glass, or any foreign bodies in the soft tissues. MRI and ultrasound are available modalities, but not routinely used for acute tendon injuries. So Dr. Kleinert and Madan did us all good by classifying the different zones for extensor tendon injuries. And these are numbered from distal to proximal, with the odd numbers overlying joints, starting at the distal interphalangeal joints, and the even numbers, everything in between. For the thumb, because there's one less phalanx, zone 1 is at the interphalangeal joints, and at the metacarpophalangeal joint is zone 3. So Doyle also added a 9th zone, and this is for the muscular area of the extensor mechanism at the middle and proximal forearm, proximal to the muscular tendons junction. So the significance of this classification is that each zone has its specific nuances and treatment modalities. So let us look at each zone. We'll start off with zone 1 tendon injuries. This is the most distal portion of the finger. So zone 1 extensor tendon injuries are superficial to your DIP joints, and the structure implicated is the terminal tendon. So these injuries usually result in an extension lag at the DIPJ, resulting in the so-called mallet finger. Most common extensor injury is the zone 1 closed extensor injury, and it frequently involves the small ring and middle fingers. So Doyle classified mallet fingers into 4 different types. Type 1 being a closed injury, type 2 being an open injury with a simple laceration of the tendon, and type 3 being an open injury with loss of skin, subcutaneous coverage, or tendon substance, and type 4 are your mallet fractures, which are further sub-classified into 3 groups, with A being your transepiphyseal fractures, which occur in children, and B are your hyperflexion injuries with a fracture involving 20 to 50% of the articular surface, and lastly, C is a hyperextension injury that involves more than 50% of the articular surface, and these are generally associated with early or late bolus subluxation of the distal phalanx. So patients that present within 4 weeks of injury are considered to have acute injuries, and those presenting later than 4 weeks are considered to have chronic injuries. So looking at type 1, this is the one that we see most commonly, and it's essentially your closed mallet finger. The most frequent mechanism of injury is a sudden flexion of an extended DIPJ, which avulses the terminal tendon off its insertion. There have been multiple studies actually that suggest there's an area of vascularity around the terminal tendon, which predisposes this tendon to rupture. And how do we treat these? So in the 1930s, it was very popular to go in and treat this with immediate surgical repair. However, the surgical outcomes were very, very poor, and that's why these days immediate surgical repair for closed mallet fingers is neither necessary or desirable. And this is because the paper-thin terminal tendon doesn't hold sutures very well, and you would have to immobilize the finger in extension post-op anyway. So currently, the standard treatment for acute closed mallet fingers is non-operative, and even certain mallet fingers with a chronic presentation have been found to be amenable to successful splint treatment. So essentially, the DIPJ is splinted in full extension for 6 to 8 weeks full-time, followed by progressive weaning of the splint. As you can see in the slide, there are many splint options available. A degree of extension lag is always anticipated most of the time. So even some papers have kind of advocated hyperextending that DIPJ when splinting. So the issue with hyperextending the DIPJ is obviously skin necrosis over the terminal tendon, which can turn into a very, very nasty complication. And how much you can hyperextend the DIPJ before causing ischemia of the dorsal skin is actually genetically predetermined and differs from individual to individual. So you really have to check this before you finalize your splint. Now, the hot topic of debate is, should you immobilize the DIPJ or not? And the answer is no, because the position of the DIPJ alone dictates the gap at the terminal tendon. And the DIPJ immobilization is not necessary and does not affect the gap at the terminal tendon. So for the non-compliant patients and those who cannot tolerate a splint, obviously a transarticular pinning across the DIPJ is always an option. What is important is, no matter what modality you choose, is you have to counsel a patient that some degree of extension lag is common, and they should be aware of that. So your dual type 2 and 3 mallet fingers are open injuries with type 3 involving skin and tendon or tissue loss. And because of the open nature of these injuries, obviously it necessitates surgical debridement of the contaminated joints, and this already lends itself to immediate tendon repair. Open repair of the extended tendon is usually done with either running 5-0 non-absorbable suture or by dermatotendinodesis, where both skin and tendon are repaired together. And then splinting with the transarticular wire post-operative repair of the sorry. Oh, sorry. I think someone was trying to. Okay, anyway, open repair of the extensor tendon is done with the is usually done with non-absorbable suture, and then whether or not to put a wire transarticularly through a DIPJ post repair is controversial. There are obviously some studies that cite even poorer outcomes when compared to just using a standard mallet splint. And then obviously your type 3 injuries, it involves a loss of skin and tendon substance. So these generally require tendon grafts and reconstruction, and also might need certain soft tissue coverage with local flaps. So moving to your dual type 4 mallet fractures, your 4A is your transepiphyseal injury. So these happen in your pediatric population. The thing to note, in kids, pure tendinous mallet fractures are very, very rare. They only tend to occur from age 11 onwards. Mallet fingers in kids often present as these transepiphyseal fractures, otherwise known as your Seymour fractures. And as you can appreciate in the bottom right picture, in kids, the extensor tendon is attached to the epiphysis, while the opposing flexor tendon is attached to the terminal distal phalanx, so they are prone to fracture. And then one obviously needs to be vigilant for the frequent open nature of these injuries, as they are often misdiagnosed as benign nail bed injuries. And failing to do so and to treat it appropriately with irrigation and antibiotic coverage can obviously result in osteomyelitis of the distal phalanx. So obviously with these Seymour fractures, nail plate is often avulsed off and soft tissue can be interposed at the fracture site, preventing its reduction. So it's usual to go in and do an open instead of a closed reduction. And we usually supplement that with internal fixation using a longitudinal K-wire spanning the DIPJ. Now, your mallet fingers associated with large dorsal fragments usually can result in volar subluxation of the distal phalanx. Basically, fracture fragments that are less than 40% of the distal phalanx articular surface don't usually sublux, whereas fragments involving more than 50% of the joint surface allow for volar subluxation. And the treatment of these large fragments in adults with or without volar subluxation is controversial as well. Some studies have shown successful results with splinting of these injuries. There's obviously no clear surgical indications for the treatment of bony mallets, but in general, injuries with associated fracture dislocation of the DIPJ are generally considered for surgical treatment. So obviously there are open and closed methods. Open methods generally is technically difficult and frequently results in comminution of small pieces of that dorsal fragment. And for that reason, we usually use a close reduction and use KY pinning using the extension block pinning as described by Ishiguro. So basically a KY is introduced into the head of the middle phalanx at a 45-degree angle, and that is used to create an extension block for that dorsal bony fragment. An important thing to note with these injuries, especially with neglected zone 1 extensor tendon injuries, is that it may lead to a swan neck deformity, especially in patients with volar plate laxity, like your rheumatoid patients. So obviously with disruption of your tumoral tendon, the lateral bands become lax, and this is compensated by the central slip hyperextending your PIP joint. And this leads to your swan neck deformity, which is obviously a different kettle of fish when trying to manage. So obviously you want to try and avoid these at all costs. Moving on to our next zone, this is your zone 2 extensor tendon injuries. And this is the area of your middle phalanx. And for your thumb, that's over your proximal phalanx. So the conjoined lateral bands and triangular ligaments are the structures generally affected in this zone. The most common mechanism of injury is direct laceration or crash injury to the finger. Generally, one functional lateral band is usually sufficient to achieve full extension of the PIP joint, and lacerations involving less than 50% of the extensor mechanism can be treated non-surgically, while those that involve more obviously will need surgical repair. So for surgical repair, core sutures obviously not technically feasible in the zone because the tendon is too thin to hold sutures. So these are generally repaired using a running suture of 5-0 or 4-0 monofilament sutures using a cross stitch or a silver skilled stitch. And alternatively, a running interlocking horizontal mattress suture can also be done. Post-operatively, the DIPJ is splintered in extension with the PIP and MCP joints free for about 6 weeks. And then moving on to your zone 3 extensor tendon injuries. These injuries overlie your PIP joint, and closed or open injuries to the extensor mechanism over the PIP joint obviously can either injure your central slip or your lateral bands, and this results in PIP joint extensor lag and DIP joint hyperextension. So after about a week or two in an untreated central slip disruption, the triangular ligament stretches out and the lateral bands migrate volarly, which results in increased PIP joint flexion. And this creates your so-called boutonniere deformity, which is obviously your classical presentation. And a clinical test that you can use to assess the integrity of the central slip is the Alston test. And the basis of this test is that when the PIP joint is flexed, that intact central slip maintains tension in the proximal portion of the extensor mechanism, and this creates slack in the lateral bands. So you can literally test this for yourself. If you try and flex your PIP joint, you'll notice that your DIP remains supple and you can't hyperextend the DIP joint. In situations where the central slip is compromised, there's no slack created in the lateral bands, and this results in a rigid hyperextension of the DIP joint. That's a very handy test to test for the central slip injuries. So the goal in the management of extensor zone 3 injuries is to prevent untreated central slip injury from developing a boutonniere deformity. Closed injuries can be managed by extension splinting of the PIP joints, assuming that both full passive PIP joint extension and full passive DIP joint flexion can be achieved, and this kind of prevents your boutonniere deformity. We usually splint these PIP joints for about 3 to 6 weeks, followed by 6 weeks of nighttime splinting. And if the central slip is intact based on the Alston test, then the patient can progress onto full active extension against resistance and active range of motion. Sometimes the central slip can be avulsed with a piece of bone of the dorsal aspect of the middle phalanx. Small fragments that are not displaced can be treated non-operatively with splinting, and then your larger fragments that are displaced by 2 millimeters or more or with associated subluxation must be surgically fixed, either with screws, anchors, or K-wires. And alternatively, small or comminuted fragments can be excised, and we generally go in and fixate these directly to bone using pull-out wires or a suture anchor. So acute open zone 3 injuries, they typically enter the PIP joint, and obviously appropriate wound management irrigation is necessary. So again, injury to one lateral band or 50% or less of the central slip doesn't require opposite repair, and can be treated with just wound care and early range of motion. And then complete transection of the central slip obviously necessitates a surgical repair to avoid putting a deformity. And there are 3 options that exist for surgical repair. These include reattachment of bone using a suture anchor, using a bone tunnel, or direct repair to the insertion itself if there's enough distal tendon remaining. And if there isn't, obviously there are different techniques or creative ways to try and reconstruct that central slip. This is a technique described by Snow that uses a distally based central slip to overlay and cross the PIP joint. The Littler method utilizes a portion of the lateral bands to reconstruct the central slip, and Matev uses a distal and proximally based transposition of the lateral slips to reconstruct the central slip at the middle phalanx. So alternatively, you can also use a tendon graft, such as your palmaris longus. And one thing to note with injuries in this zone is that your wound closure over the extensor tendon repair must not be under any tension with the PIP and DIP joints fully fixed. So if this is the case, you have to do or prepare to do a flap, such as your island pedicle flaps or metacarpal artery flaps to make sure that supple skin covering your repair. Moving on to the next zone, which is zone 4. The zone 4 injuries pretty much lies over the proximal phalanx. In the thumb, it lies over the metacarpal. And in the zone, the extensor tendons are typically wide and round enough to hold core sutures of 4.0 or 3.0 in caliber. And because the convex nature of the proximal phalanx, these dorsal lacerations are frequently associated with only partial tendon injuries. They're also frequently associated with fractures of the proximal phalanx. So again, the management of these injuries is very similar to your zone 2 injuries with complete tendon lacerations or partial lacerations greater than 50% requiring surgical repair. Suture configurations generally recommended are your 4 to 6 strand running interlocking horizontal mattress sutures. And then obviously care must be taken not to perform a repair that is too tight, because bunching of the tendon at the repair sites can lead to metacarpal joint extension contracture. Now, moving on to your zone 5 extensor tendon injuries. These are injuries that occur over your metacarpal phalangeal joint. In the thumb, it can involve your extensor pollicis brevis, your abductor pollicis longus, and your extensor pollicis longus. And in addition to your central slip, your sagittal bands can also be injured in this zone 5 injuries. So your clean tendon lacerations at the metacarpal phalangeal joints can be obviously repaired with 1 or 2 core type sutures, followed by a 5-0 cross stitch, or you're running interlocking horizontal mattress sutures again. And then obviously with these associated fight bite injuries, you have to be vigilant about open tendon injuries over the metacarpal phalangeal joint, especially when a patient has sustained one as a result from striking someone in the mouth. So these wounds are often heavily contaminated and communicates with the metacarpal phalangeal joints. They generally appear innocuous initially and go on unrecognized until it becomes infected and you're dealing with a septic arthritis. So you have to exercise a very, very high index of suspicion in these injuries. So with fight bite injuries, an X-ray is usually mandated to exclude any fracture of foreign bodies, and obviously urgent surgical debridement and arthrotomy is absolutely necessary. Your sagittal band injuries, although very, very rare, they can also occur in the zone. Closed sagittal bands injuries don't really occur. They generally occur with your rheumatoid patients and usually involve the radial sagittal band of the middle ring finger. This condition is obviously mistaken for trigger fingers because of the snapping sensation that occurs when the extensor tendon subluxes and reduces off the metacarpal head. And then non-operative management is generally employed for acute closed sagittal band injuries. The finger is usually splintered in this yoke splint with the metacarpal phalangeal joint in extension and leaving the interphalangeal joints free. And for your open injuries or those that have failed complete trial of non-operative management, direct repair of the sagittal bands is generally performed. Then obviously, if that fails, we've got multiple methods of reconstruction that have been described using the junctura tendinum, the central slip, or the proximal central tendon of the EDC. Then moving on to your zone 6 extensor tendon injuries, this generally lies over the dorsal hand, and they'll probably have the most favorable prognosis, obviously for several reasons. One, they are unlikely to be associated with joint injuries. There's greater tendon excursion, which means that limitation of motion will not lead to significant loss of joint motion seen with injuries over the phalanges. There's increased subcutaneous tissue over this region, and that lessens the chance of adhesion formation, and coarse sutures can be easily placed for the tendons in this region. So partial or single tendon injuries in zone 6 obviously can be masked by the adjacent junctura tendinum, as we described earlier, and that generally maintains the extension of the injured digit through the intact adjacent extensor tendon. So because of this, diagnosing zone 6 extensor tendon injuries may be quite challenging. So any amount of extension deficit or extension lag is an indication for surgical repair. If the primary repair is possible, and this can generally be done with 3/0 core sutures, and obviously if it's difficult or impossible, or there's a tendon gap, then tendon reconstruction is then done with tendon grafting or with a tendon transfer. Moving more proximally to your zone 7, this is the area over your wrist. Now, this is comparable to your zone 2 flexor tendon injuries in that the repaired tendon generally lies underneath a tunnel beneath the extensor retinaculum. The extensor retinaculum can be incised to allow for exposure and allow for the tendon to be repaired. The thing is, you have to preserve a small portion of the extensor retinaculum to prevent bowstringing of the extensor retinaculum. And obviously in the zone, again, with your zone 6, you can employ nice, thick, big core sutures of 3/0 diameter, and you can supplement that with a cross stitch. Even more proximal injuries in your zone 8, which involve your muscular tendons junction. These repairs in this zone obviously is a bit more difficult because they have very, very tenuous holding power in the muscle tissue. So if the repair in the muscle is pretty flimsy, then generally what we do for these injuries, we do a side-to-side tendon transfer. And then in zone 9, which is proximal to muscular tendons junction, muscle bellies, we generally repair these with multiple figure-of-8 sutures of the fascia. And then what's important to note with these more proximal injuries, obviously with penetrating trauma, such as with a knife or by glass, there's generally associated nerve injuries. So you have to examine for these with your clinical examination. So operative management, there's no real clear gold standard in management. Generally, the general rule of thumb is surgery is indicated if there's more than 25% of tendon involved, there's an obvious extension lag or an open contaminated wound, or if there's a associated unstable joint, or if conservative approach has failed. So if a repair is undertaken, it should take place soon after the injury, and certainly definitely within 2 weeks from the time of injury. And tendon injury repair can include a primary repair, a secondary repair, or immediate reconstruction, or a staged tendon reconstruction in your significant gross injuries with tissue loss, or ultimately with tendon transfers. So obviously the greater number of tissues involved in the injury, the more challenging it is to restore hand function. So I've just put a couple of slides together for those who are more surgically inclined. So these slides kind of look at the different suture configurations, and as you can see, there's a myriad of suture configurations which have been described for extensor tendon injuries. The key point is when it comes to repairing extensor tendon injuries is that surgeons should base their treatment on the characteristic of the tendon at that specific zone of injuries. The extensor tendons along the dorsum of the hand are obviously much more thicker, averaging about 1.75 millimeters. And this narrows to just 0.65 millimeters after it crosses the metacarpal phalangeal joint distally. So you can't really use nice, thick core sutures. So this slide just kind of shows the data of a study that compared the various suture configurations, and they concluded that the modified Becker was the strongest repair. However, if you look at it closely, it's a very, very complex suture configuration. So the strongest suture configuration is not always the easiest one. In a study done by Lee et al., they found that a simpler running interlocked horizontal mattress suture was the way to go, and they compared this to the more complex and stronger modified Becker techniques. And generally what the suture, as the name suggests, it basically combines a running suture with an interlocked horizontal mattress suture. And they found that the suture configuration is actually much more stronger and quicker and easier to perform than all other suture configurations. And for this reason, it's become a popular suture configuration for extensor tendon repair. This is just another study that shows the running interlocked horizontal mattress suture, comparing the ultimate tensile strength to other easier epidendous repairs. And you can see that it is still the strongest one. It also has a higher resistance to gapping, and also prevents shortening of the tendon, which may ultimately lead to loss of flexion of the fingers. So in 1990, Newport et al. Reported on the long-term outcomes of surgical extensor tendon repair. And what was interesting was that they found that the fingers that underwent extensor tendon repair, the fingers that had extensor tendon repair lost the ability to flex fully, then lost the ability to extend. So the loss of extension wasn't really the main issue. The main issue was the loss of flexion, because it shows that injuries in zone 1 to 4 had the worst outcomes than injuries more proximally. Now, what that highlights is that the extensor mechanism is very, very complex, and that these injuries are not easy to treat, and that they are not forgiving in the sense that if you shorten the extensor tendons, you actually lose flexion, which is the main disability, not the loss of extension. So in conclusion, extensor tendon injuries occur very, very frequently. An in-depth understanding of the intricate anatomy of the extensor mechanism is necessary for diagnosis and for management. And extensor tendon injuries definitely poses its own challenges and are extremely sensitive to length discrepancies. So these injuries obviously deserve careful attention in the diagnosis, treatment, and rehabilitation. And obviously you need that to offset the potential loss of function. And that is especially the loss of flexion. So yeah, that's pretty much what I have for you. It's just a very brief and concise overview of extensor tendon injuries. I know it's a lot of information, but I'll make it as brief as possible. Any questions?
Thank you so much, Dr. Fang. That was really a wonderful and very well laid out overview of the different injuries and the different treatment approaches. There is a couple of questions. So one of the questions is around, in the open injuries, you spoke a bit about needing to make sure that you debride very well, that there might be a need for antibiotics. So there's a question here around the choice of antibiotic, and also then just kind of comparing prophylactic antibiotic versus therapeutic. So really just understanding, where would you potentially use Kefsar, where would you use Augmentin, and what would be the choice of antibiotic if you were looking at a prophylactic antibiotic versus a therapeutic antibiotic choice?
So obviously for empiric antibiotics, we go for broad spectrum antibiotics. If it's just only soft tissue related, Augmentin will suffice. We do utilize cipazolin in injuries that associated like bony injuries such as fractures, or those that penetrate the joints, and that's mainly because of better bony penetration with cipazolin. But the cover is pretty much the same. Obviously, this differs from which location and the bugs that you grow at your institution, but generally, yeah, a broad spectrum antibiotics such as augmentin if it's purely soft tissue, and Capsule if there's any bone involvement.
Thank you. That's very helpful. And I think just a follow-up question to that. I think you did touch on a little bit, but just maybe to kind of get back to it in terms of human bites or human bites to the hand with tendon injury and with the risk of sepsis and cellulitis considered, is the need to just do a washout or do you need to do a debridement? So what would be sort of the best approach?
So it is necessary to do a full-on arthrotomy. I mean, for those injuries, any suspected injury for fight bites that's close to metacarpophalangeal joint, I go in, I do extensive debridement, go in and open and do a arthrotomy of the joints actually, because you never know, whether a tooth has penetrated the joint. So rather open it out, wash out the joints, and then you can close the joints afterwards. But yeah, with fight bites, generally just go in, do a full-on arthrotomy, don't take chances. A general superficial washout doesn't really suffice. You may be kicking yourself later on when the patient develops septic arthritis. So really exercise high index of suspicion and be very cautious and vigilant with these injuries. Yeah.
Thank you so much. I don't know if there's any, oh yes, there is a follow-up question. So just a question here asking if you could please elaborate a bit on trigger finger.
For trigger finger?
Yes.
So trigger finger is actually, yeah, so now we're looking on the other side at your flexor tendons, right? So on your volar aspect, you've got your deep flexor tendons, you've got your superficialis and profundus, and at the level of the metacarpophalangeal joints, right, it traverses through a very intricate system of pulleys, right? The first one being at the metacarpal neck or at metacarpal head. That's generally your A1 pulley. Now, what happens with overuse? You get a lot of synovitis around tendon sheath, and then that causes a lot of inflammation and swelling. And then what happens is that your tendon battles to transverse those pulleys. With it becoming more severe and with more severe swelling, the tendon obviously becomes stuck and then causes triggering. And then obviously in more severe cases, it causes actual locking of that specific finger. These are generally treated with therapy initially, and at the non-surgical means also involve doing anti-inflammatories, corticosteroid injections, and failing that, surgical release is obviously necessitated. So yeah, it's a very, very common condition. No.
Thanks for that. Another question is just around what would be the point of, or when would a general practitioner or an ED practitioner dealing with an extensor tendon injury, at what point would they be advised to refer on to a specialist hand surgeon?
So like any suspicion with an open injury, okay, with an associated fracture, with an associated nerve injury, any open injury with an associated extensor lag of the fingers, I think does necessitate, like careful evaluation by a hand surgeon, because if there's an associated tendon injury, then most, especially in the open ones, it will necessitate surgical repair of those injuries. So I mean, if you're unsure of it, especially in zone 6, sometimes those fingers are, those extended tendon injuries are compensated by the adjacent intact tendon. The evaluation might be a bit tricky. So if there's any doubt or concern, it's best just to, refer on to your hand surgeon, have them assess and evaluate the patient, and then decide whether surgical repair or rehabilitation or appropriate splinting is necessary.
Thank you so much. I think that has been a very, very informative presentation. I see another question here asking, when do you recommend loading the hand again? And I guess this might obviously depend on the sort of the zone of the injury, but if you could maybe just give us a bit more on that. When do you recommend loading the hand again?
So yeah, definitely differs, on your zone of injury. Obviously, like, zone 1 injuries, mallet fingers, you want a much longer period of immobilization. We generally go for 6 to 8 weeks with a period of weaning after that. For more proximal ones, generally, it all depends on the percentage of tendon involved. It's less than 50%, 1 or 2 weeks of immobilization is fine. But obviously with your complete ones or ones that are post-operative repair, they will undergo a strict rehabilitation protocol, and we generally only start loading from 6 weeks onwards.
Thank you for that. I'm just watching the chat to see if there's any other questions coming through. We'll just give it a little bit of time. But while we're sort of just waiting to see if there's any other questions coming through, in your practice, would you work in a multidisciplinary sort of setting? So are there sort of OTs and physios that you would work with in terms of the rehabilitation aspect of the injuries?
Oh, no, of course. I mean, look, the OTs make us look good. So we work hand in hand with them. They are fantastic. And they are, a necessary part of the treatment. Surgery is only, in our time of patient, surgery is only 50% of the treatment. The rest is, rehabilitation. So it is essential that they undergo a very stringent and appropriate rehabilitation program. So yes, yeah.
Okay. No, that's wonderful. Okay, I'm not seeing any further questions come through. So in light of that, I just want to say thank you so much, Dr. Fang. That was a very informative and very useful presentation. Thank you for your time, and thank you to everyone who's joined. This is the last Waxing Clinical event for this year. We'll be kicking off again next year in February. So please just keep an eye open for that. We're going to be doing a bit more of, we're going to be doing a mix of different kinds of events. We want to introduce patient-facing events as well, which is going to be very interesting. But otherwise, thank you so much. Thank you for joining. And yeah, please feel free to respond to the survey that should come to you straight after this presentation. So thank you.
Thank you very much. And thank you very much for the time. Thank you.
Thank you. Bye.